We're going to go ahead and start the webinar now. I hope everybody's ready and excited for this. I know I am. I'm here in sunny Boulder for the day that was actually a little bit rainy, which was nice for a change, and watching the hummingbirds out of my window. But beyond the bedroom, we provide a safe environment to learn, explore, and find answers to empower you to improve relationships, ignite your passion, and explore what's possible in your sexuality. We do this through these monthly webinars, through monthly seminars that are more in person, and then our primary conference, which is held in October here in Denver. Tonight we have Dee Hartmann, and I'm going to let Elizabeth talk about her in just a moment. No, I'll just go ahead and let her talk about her now. So Elizabeth, you want to take over?
That's great. Thank you. So welcome, Dee. Dee Hartmann is here to present for us Sex, Really? Not Tonight, When Sex is Painful. Dee Hartmann and I met in 2004 when we were both working in Chicago for a multidisciplinary facility working with women's health and women's sexuality. Dee is a master physical therapist. She works with the pelvic floor, as she will describe for you. I actually have worked with Dee around my own pelvic floor issues. I wanted to know what she was going to be taking my clients through, and I got to tell you, it's something worth exploring. It is an amazing way to help actually both men and women improve pelvic floor function, and for us women, reduce painful sex, painful intercourse. Dee has become a dear, dear friend of mine. She is an amazing mother, brand new grandmother, and she and her husband David have been married for 36 years, 37 years, almost 36 years. And you two, actually, Dee, are an inspiration for my new marriage. And the moment I met both of you together, I knew that you were something, that you're a role model for those that are really seeking the type of relationship that you two have created together. So it's with great joy and great honor that I present Dee to take us through Sex, Really? Not Tonight, When Sex is Painful. So I'm going to turn it over to Dee.
Thanks, guys. Dan and Elizabeth, I can't thank you enough for inviting me to participate in this wonderful, wonderful situation where I'm able to reach people that I can't get to in my office. I've been in a physical therapy private practice now for over 22 years here in the Chicago metropolitan area, where I have focused my practice on treating people with chronic pelvic pain. That's men and women. Primarily, the biggest part of my patient population over the years has been women who have been sent to me with complaints of chronic vulvar pain and sexual dysfunction. I've had the joy and wonderful pleasure of working with Dr. Domina Renshaw at Loyola University in her sexual dysfunctions clinic, which has been a wonderful integration of therapies for me to use when I see my patients. It's delightful to be with you tonight. The only thing that I can think of that would be better would be if we could all be in the same room where we could really just sit together and chat. I'm much more about discussions than throwing lectures at you, but this is the best way that we have to get to this.
And with that said, we will chime in from time to time with questions, and we did have a number of our participants send questions in ahead of time so that everything would be really private. We won't use names. But we will, those questions hopefully will be answered throughout the course of the presentation. And for those who aren't, we'll try to address those at the end.
Great. Thanks, Dan. I forgot to mention that as well. So hopefully if you did send in questions, you'll get answers along the way. And if not, you can let us know, and we can deal with those after the seminar as well. This is just my little personal disclaimer. I've known Elizabeth and Dan for quite some time. I know that we all talk a lot about the same things, but I don't begin to suggest that what I'm saying is connected and representative of those views of beyond the bedroom, even though a lot of our ideas are the same. Dear everybody out there, those of you who are here, those of you who aren't, those of you who have friends and neighbors and sisters and cousins and aunts who have problems, I'm so sorry your vagina hurts. It's a horrible problem to have to deal with. Before we go into more details, I want to just suggest to you that there are two really main groups of women who have vulvar and vaginal pain. There are those who start with pain. It might be with the first time they try to use a tampon. It might be the first time they try to have sex. They may even look back in their history and see that they never really liked to ride a bike, or they never really liked to wear tight jeans. It may have been somebody who had a hard time toilet training, and their mother always told them to hold their urine, don't let that leak. Those women have pain the first time they have sex and oftentimes go into deep depression thinking, geez, I'm never going to be able to have sex, I'm never going to be able to get married, and I'm never going to have babies. The next big group of women are those who have perhaps had pain-free intercourse. They may have changed partners, they may have gotten a new job, they may have had surgery, any number of things that we'll talk about in a bit that may cause problems, and things just start getting uncomfortable and they get progressively worse, and over time sex is just intolerable. It's too uncomfortable. There's too much pain to even withstand having intercourse at all. The first group of women we refer to as those with primary dyspareunia. Dyspareunia is generalized pain with sex. The women in the second group are those with secondary dyspareunia. And the reason I go through this is to let you know that there are those who have pain from the beginning and those who can have pain-free sex and start having pain. And that's a really very important focus to have when dealing with these problems, because oftentimes people think, well, it didn't hurt before, it shouldn't hurt now. Or the converse to that is, well, it always hurt, I suppose it always should.
What is the prevalence of one group in your practice versus the other?
The biggest portion of women I see with vulvar pain are those who have had it as a secondary problem. Probably 30%, 35% of those primary who had it from the very beginning, and 60, 75, 60, I can't remember my math here, whatever the rest is of those who were okay and then it started to hurt. So it's kind of a mix between the two, but more of those who have had pain-free intercourse and then start having pain. Some of the things that I want to cover tonight are, how the heck can I talk to my partner about this? We don't want to begin to assume from the get-go that this is only a heterosexual problem. It certainly can be a problem between two women as well. What causes pain down there? Do we really know? Should I talk to my doctor about it, and how can I do that? And is there anything that I can do to just make it go away and either start enjoying sex for the first time or start enjoying sex again? There are several very important questions, and I hear these all the time in my practice. Should I just stick it out and just do it even though it hurts? Or should I say no all the time? Should I have it sometime? Who decides? And how can I make my partner spouse know that there's still love in our relationship, but there just is something that isn't right? These are all questions that I hear all the time, and people coming into my office trying to figure out how to deal with these issues. This is the first of several slides to just remind us that boys and girls don't think alike. If you look in this upper left-hand corner, this is the Dodge emblem. Interesting, I'm sure you've all seen it many times before. What you may or may not have seen is that this is the female reproductive tract. This is the vagina that leads up to the cervix and the uterus, the fallopian tubes on either side, leading to the ovaries on either side. Do you see a similarity here at all?
So you're saying that the auto manufacturers were actually thinking women?
Isn't it interesting? Who the heck knows what they were thinking, but they certainly perhaps had an ulterior motive when they designed it that way. Who knows? We also have this lovely G-point mouse here. Interesting if you could just use your imagination. And this, the cartoon down below, I just love. Many of you may have seen on Facebook, I know a lot of people had posted what it would be like for a man to go through labor. and it really does just really evoke some really interesting thoughts. I always say that if men had to have our babies, we would have been extinct hundreds and hundreds of years ago, because heaven knows they never would have had a second after the first.
Well, and I really like that G-spot mouse that's in there. I can't tell you how many times I've coached men through clitoral stimulation on women, and they just don't get it. It's like, go slow and light. And, you know, really, when you're rolling the mouse wheel, that's probably still want to do a little bit lighter than that, but most men seem to think that it's got to be even harder than that.
Very good point. And when women have pain, that oftentimes is a problem, because pain can be all the way up into the clitoris and a real issue. So yeah, good instruction there.
Would you say that some of the times that the women or men that come to you, the pain isn't necessarily dyspareunia? It may be actually a physical action that's going on between the man or woman and their partner?
Well, I mean, dyspareunia by definition is pain with intercourse. So that certainly is the interaction between the two. Other women there are people who can have clitorodenia, pain in the clitoris. Other women may have pain, and we'll get to this in a little bit, generalized vulvodynia, pain throughout the perineum, and they can't have sex. Others may have back pain or hip pain. There are all sorts of things that can stop sex from happening and can cause pain. So, you know, we'll get into those in a little bit, but yeah, there are all sorts of things that we think, anyway, can contribute to it. The bottom line is sex should never, ever hurt, even a little bit, even if it always has. And again, I often hear women say, I always just thought it should hurt, because every time, from the very beginning, every time I've had sex, it hurts, and I just put up with it because I just thought that's the way it's supposed to be. And I'm here to suggest to everyone out there that that just isn't the case. Sex shouldn't hurt. So do we really know what causes it? You know, I just talked about some things, and we'll get to that too, but sometimes we just don't know. In particular, those with primary problems, they just happen. We may be able to look back in history and see some things that may have contributed to the problem, but obviously we can't go back and get rid of that problem and see if the pain doesn't start. So it's really hard. There's some that think that it's a problem when babies are forming in the uterus, that it's a problem with the tissue that forms in and around the outside of the vulva, even such that that tissue comes from the same origin as tissue in the belly button. And there are a lot of women who have pain that's primary that also have really sensitive belly buttons. A hypothesis out there from the medical community, maybe we need to start checking women's belly buttons. I've not found it to be the case in my primary patients, but that's just some of the things that we look at. But we don't really know, and we can't really tell, again, because we can't go back and make it different.
When you find pain in the belly button, what typically causes something like that? Is there something you can diagnose?
We think that it was actually during the embryonic development, and that it's from the tissues are both from the urogenital epithelium, and it's a problem in tissue formation. Again, that's just one hypothesis. It's not been proven, but there are physicians who out there who think that they're very, very connected. Again, I haven't seen it by any means being the majority of my patients with that, so we think it was just when the body was forming. So there are other things that we look at and we think may be contributory. And I have a list of things here. This may ring true for some of you who are listening in. It's people who have had a history of chronic urinary tract or yeast infections oftentimes have pain with sex over a long course of time. Women who have had problems with painful, crampy periods over the years. If you have chronic bowel problems, you have chronic constipation or chronic diarrhea, or bladder problems, you have urgency, frequency, or your bladder just bothers you all the time. Chronic low back and hip pain, tailbone pain, sacroiliac pain can contribute to vulvar pain. Having a decreased sex drive, a lack of lubrication, and a lack of foreplay can certainly contribute to pain. We know from the literature that there are actually 5 things that have a tendency to go along with vulvar pain. Fibromyalgia is one of them. Jaw pain is another. Bowel problems, IBS, interstitial cystitis, bladder problem, and vestibulodynia oftentimes are seen together in many women. Hormones, again, there's a certain group of physicians out there who think that oral contraceptives can also contribute to vulvar pain. We know that women on birth control, the purpose of the birth control is really to shut down the person's own estrogen production so that you stop ovulation. Well, what oftentimes happens with that as well is that the skin around the outside of the opening of the vagina gets very thin and very tender and very sensitive, and there's less mucus produced in the vagina. I've had a physician equate it to women on birth control pills often have vaginas that look like 80-year-old women's vaginas, which isn't a very pretty picture. There was a physician who did a study with 17 women on birth control pills who had vulvar pain and painful sex, took them off of it, and all of them got better, got rid of the pain with sex, put them back on birth control pills, if you can imagine that, and they all got the pain again. So there are some studies out there, that was an unpublished study unfortunately, but there are some thoughts that that could be a problem. A history of abuse certainly can't be ruled out. Physical, emotional, sexual, it doesn't really matter. Any type of abuse can cause such tension in the body, just as stress can. And anytime all of these things happen, from the stress to the yeast infections to the abuse, what we see is the body responds by holding tight. We're going to look at the anatomy in just a little bit, but if you can imagine and think, if you've ever had a yeast infection or if you've ever had a bladder infection or hip pain, you think that you might imagine how you might just hold so tight against that. You may not know what you're doing or why you're doing it, and again, I'm going to show you in just a few slides of what you're doing, but when you do that, the entire region of the pelvis just has a tendency to shut down and get tight. Should I talk to my doctor? Absolutely. I can't encourage women enough to be patient, but to really try to let them know what's going on, if nothing else, to educate them. Sometimes physicians are going to understand, and sometimes they say they understand, and other times they may be absolutely clueless. The problem is that physicians aren't taught this in med school. And quite frankly, there have been surveys that physicians suggest that they don't ask about pain with sex because if a woman says yes, they have no idea what to do to help them. A number of physicians do and are very good and have association with sex therapists and counselors, but lots of them just really don't ask because they don't know what to say if you say yes. However, if you do have pain and you're going in for a yearly exam or your first exam, please, please ask them to be gentle and ask if they have a pediatric speculum. That's that thing that goes inside that they spread your vagina open with so they can see to the inside, which they need to do. They need to check you out. But a pediatric speculum is just smaller, so it's not quite so intrusive. It may still be very uncomfortable, but at least it's not as big as a regular speculum.
Dee, when you say that doctors don't ask the question because they don't quite know what to deal with or how to deal with it, is that general practitioners or is that gynecologists, urologists, or all of them?
Well, unfortunately, I think it's not just limited to internists and general practitioners. I think that, unfortunately, there are a lot of gynecologists who are equally as uneducated and unable to address it. I have been involved with this practice in treating women for 20 years, and we talk to them and talk to them and talk to them. We write papers, we do lectures. We try to get to them, but it is certainly across the board with all specialties. I really would like to emphasize that it's not just women who understand and who are patient and kind and gentle, because there are as many women physicians who aren't, who are rough, who are not understanding, as there are men, and there are certainly many, many, many male physicians out there who are incredibly wonderfully kind and gentle. So I don't think it's a male-female doctor thing. I oftentimes have patients calling me saying, I want to talk to a female physician because I know she's going to understand. And I found through my years, and I've been in a number of doctors' offices watching what they do, that that's just not the case. If your doctor sends you for an ultrasound exam where they're going to check and make sure your uterus and your ovary is okay, just make sure you tell the technician when you go in for the ultrasound exam that you have pain before the test starts, and please ask them to also be gentle. Deep breathing can help as they put that wand in there, but just let them know that you have issues. Something that often happens in internist office as well as gynecology offices is they think they need to do biopsies. Biopsy is where they take a little piece of tissue out of the skin around the opening to see if there's a problem with it. And unless they can really see a very gross dermatologic problem, there really isn't a lot of reason, if you just have pain, to have a biopsy, because it is typically inconclusive and comes back just with inflammation, which is pretty evident.
So Dee, can I ask you another question in regards to the doctors and those that, as the title says, what if my doctor just doesn't get it? I'm curious, can a woman just come directly to you, a pelvic floor physical therapist? And I know things are changing as we move into Obamacare, but do you have to have referrals? Wouldn't I be able to just call you if I was seeking your types of services? Who are the doctors that we should look to or look for advice on this?
Sure. That's a great question. Illinois, which is where I am, is one of 2 states left in the country that does not have what we call in the physical therapy world direct access for treatment. In every state, a physical therapist can evaluate a patient without a physician's referral, but then after that, in the state of Illinois, and I'm not sure what the other state is, it used to be Indiana, but they just passed it. In order for my patients to be treated, they need to see a physician for a written order. Other states are able to see patients, do an evaluation, and do treatment. However, it may be only a month or maybe 30 days or 60 days before they need to see a physician. Throughout the United States, anyone can call a physical therapist and go in for an evaluation. We'll talk more about that too, and ways to do that and find physical therapists in just a bit. If your doctor really just doesn't get it, there are people out there, I promise, who do. I know it's hard, but please try to find another healthcare provider, call other practices, and talk to them about whether or not they treat women with pain. Oftentimes, nurse practitioners have more time, and I think they have a little bit different educational process, and they're a little more aware of what happens when women have pain with sex. I've also listed 3 different organizations here, all of which can be helpful in finding healthcare providers in your area, hopefully. It's not always guaranteed. They're not always physicians, nurse practitioners, or physical therapists in your area, but it can at least give you an idea. The National Vulvodynia Association is a self-help group that is now worldwide that has done amazing things for women with chronic vulvar pain as far as research goes, raising awareness, publishing papers, getting the NIH, National Institute of Health, to do research and to be aware that this is a huge problem. The International Society for the Study of Vulvovaginal Diseases is also a group of mostly physicians around the world who deal not only with vulvar pain but vulvar cancers and vulvar dermatological problems. The International Pelvic Pain Society is about half and half physicians and physical therapists. Again, it's an international society that deals with chronic pelvic pain, including vulvar pain, but pain in the abdomen, pain in the pelvis, and pain in all areas between the respiratory diaphragm and the middle of the thighs. One of the best ways is to ask your friends and see who they see. See if they have a physician who they feel is kind and compassionate, who takes the time and who listens. Unfortunately, gynecologists' biggest business is delivering babies. So any of you who have been fortunate enough to be pregnant and go through a pregnancy with a gynecologist, with an obstetrician gynecologist, know that those visits are typically quite short. So their practice is built on short visits. Unfortunately, when there's pain issues, it usually takes longer, so it's a little more burdensome. So you really need somebody who is caring and compassionate and willing to talk about your problems. So physical therapy. I've been asked this question so many times, and people will sit down in front of me and they kind of screw up their eyebrows and say, my doctor told me I needed physical therapy. I thought it was the strangest thing ever. Actually, they told me I should come to you last year, and I thought it was really silly then, but I just went back for my yearly exam again, and things are still bad. So my doctor told me again I should come to physical therapy, so that's why I'm here. Ask your doctor if they refer to physical therapy, and it's typically women's health physical therapists. And if they do, you want one certainly who deals with vulvar pain and sexual dysfunction. Not all of them do. Some of them say they are women's health physical therapists, but they may only deal with issues like incontinence or breast reconstruction, fibromyalgia, those more female disorders. But just call and ask specifically if there's a PT in your area who deals with painful sex. Another way to locate someone who might be more apt to do this is looking on the website of my professional association with the American Physical Therapy Association in the section on women's health. You see the web page there. On that you can find a practitioner finder tab that you can go and put in your location and hopefully find someone that you can at least call and ask whether or not they do this.
Yeah, and this is not to be confused with the physical therapists that deal with knees and shoulders and things like that. Is that correct?
Right. Women's health physical therapists certainly do deal with those things. In particular, we talked about low back pain and hip pain being a problem. We don't just solely focus on the pelvis and leave the rest of the body out of the equation because everything goes together. But a physical therapist who may only do knees and ankles probably does not do women's health. So you have to be very specific. Make sure that the PT that you're going to deals with that. The MVA and IPPS also does have referrals as well. So what's the general medical term? I've already mentioned it in the second or third slide, and that's dyspareunia, a big word that really just means pain with sex, either caused by some medical problem or some psychological problem. Very general. You'll hear it a lot. It actually can refer to men with pain as well. However, the biggest demographic of people with painful intercourse is women, but men certainly can be included in that group as well. So if you really are trying to find somebody to diagnose the problem and you make it into a gynecologist, for instance, chances are they may diagnose your problem as vulvodynia or vulvar vestibulitis syndrome, and that, by definition, is chronic vulvar pain with no other identifiable diagnoses. They're going to say that they're going to touch the outside of the opening of your vagina with a Q-tip, and if you have pain in and around that area, but they can't find an infection, they can't find an overall inflammatory process, they can't find a neoplastic change or cancer there, and they don't see any real neurologic damage or issue, then they're going to call it vulvodynia, or as the most current terminology that we're using today for pain just with touch is vestibulodynia. Not to confuse things, but vulvodynia is actually divided into a localized problem and a generalized problem. A localized problem is what we're talking about, primarily just pain with sex, but you're pretty much okay the rest of the time, unless you try to touch the opening, if you try to put a tampon in, or you may try to wear tight jeans with a thick seam. You try to ride a bike, gynae exam. Those kinds of things hurt, but other times you do okay. Generalized vulvodynia is where you have pain and burning that's unrelenting. It can be in the whole area between your legs. It may be 24/7 such that you can't sit, you can't wear pants, you can't wear underwear, working becomes impossible. There have been women with generalized vulvodynia who have been totally bedridden as a result. There's some question as to whether there is a continuum between vestibulodynia and generalized vulvodynia, but in the 20 years that I've been involved with this, no one has suggested that that really occurs, that someone who starts with vestibulodynia over time will not progress to generalized unprovoked vulvodynia. As a matter of fact, there's a researcher here in Chicago who's just starting to look at this, to look at women who have had pain for less than 3 months and follow them, and she's actually going to follow them with brain MRIs to see if their brain changes over time and to see how their symptoms change over time, which should give us some better information. If you happen to make it into the office of a urologist because you're having bladder issues, you have pain in your bladder when it fills, you may have pain above your pubic bone in your belly, the doctor may suggest that you have painful bladder syndrome that goes along with your pain with sex, but again, it's pain in the bladder, but they can't find anything that's causing the pain. There's no infection. There's nothing else going on in there that's causing the pain. It just hurts. If you happen to make it into the office of a psychologist because your gynecologist has told you you're crazy, there must be something horribly wrong with you, you may hear the term vaginismus. Vaginismus is an involuntary contraction of the muscles around the vagina. It's a little bit different than what we were talking about before. It certainly interferes with sex, causes tremendous, tremendous distress, but it doesn't always have pain with touch. It could be that a woman, for whatever reason, is anxious and has such fear of penetration, perhaps from abuse, perhaps from a rape, something that happened in her childhood that we really don't know about. She has such fear that her body totally tightens up. She pulls her knees together. You can hardly get in to get a vaginal exam or to even touch the outside of the vulva because she just can't stand for you to be there. Some vaginismus patients who I've seen also do have pain, but that, in my professional opinion, is a vestibulodynia on top of a vaginismus and that severe holding and fear that goes along with it. This is my world. This is a drawing that a diagram that I used in a paper that I published several years ago. It suggests that this is the outside of the pelvic floor. These are the labia down below, and that the pelvic floor really extends all the way up and through the organs of the pelvis. This is the pubic symphysis, the bone in the front. This is the base of the spine, the sacrum and the tailbone coming down here. This white that you see is actually the connective tissue that goes from the back all the way to the front to support the uterus, which is here in the middle. This is the fallopian tube here that comes down to the ovary. Remember that Dodge symbol? We'll look at this in just a second, too, in more anatomical terms. And if you go forward, there it is. You go forward, you see the bladder that sits right behind the bone in the front, right where if you have that suprapubic or that pain just above your pubic bone can be because of bladder pain. Below that, you start to see the pelvic floor muscles. I use this when I do education with physical therapists and physicians, nurse practitioners, to give them a sense of the anatomy and what we need to treat in order to get to the problems that occur at the opening. This may be a little more familiar, hopefully. This is the area behind the hairy part of the pelvis, the mons at the top, down to the anal opening that we refer to as the perineum. The legs, as you can see, go up on either side. The butt cheeks are down here. We go back to the top. We see the big lips of the labia majora on the outside, on either side. They're paired. And the labia minora, or the small lips, on the inside. We come to the top and we see the clitoral hood covering the clitoris. We come down a little bit from that and we come to the opening of the urethra, which leads up to the bladder to empty the urine. Below that, we see the vagina. This area we refer to as the vulva. It's the opening of the vagina. When doctors check to see if you have pain, typically they'll touch with a Q-tip all around this area to see if there's pain. We refer to this area as the posterior fourchette, and that's where a big part of the pain comes with sex.
When they're using that Q-tip to push around the introitus area, what are they looking for when they're doing that?
Pain.
To just pain? No,
Just
nothing specific?
Nothing specific. They may also use the Q-tip and touch the labia out here. They may go up and touch the clitoral hood. They may touch around the urethra as well. But we're just looking to see if there's sensitivity in this area. And again, if they see that sensitivity, that's the gold standard for diagnosing vestibulodynia. When I see patients, I don't use a Q-tip. I use my finger. I do what I call a modified Q-tip test. And I typically test over here. If you think of the clitoris at 12 o'clock and the rectum at 6 o'clock, I check for pain at 3 o'clock. I check for pain at 6 o'clock. And I check for pain at 9 o'clock because those are the most prevalent areas for pain.
And why is that? Or do you know?
Well, if you had that answer, we'd be traveling around the world doing what? We don't know. We don't know. The area in between the vaginal opening and the anus is the perineal body, and below that is the anus. And again, with that chronic urinary tract infection, that chronic yeast infection, that low back pain, this entire area just literally clams up and goes into spasm. I wanted to show this. This is a Netter slide. These are very, very famous anatomical pictures. This is what you look like if I cut you from the belly button back to the sacrum or the tailbone behind. And I think this is a real important picture for people to see because it gives you an idea of where things are located on the inside. This is that pubic symphysis in the front where the abdominal muscles come and attach to it. If we go down the middle, the labia are here, labia majora, labia minora here. We have the clitoris here. We come a little bit further and we have that opening of the urethra that leads up to the bladder. The bladder sits right behind the pubic symphysis. We come back a little bit further and we have the vaginal opening. It can be called the introitus. It can be called the vulva. Leads up into the vagina. We have the cervix that's right here at the base of the uterus that typically lays over the bladder in that position. It can be in a number of positions, but this is normal uterine position. And if we come back a little bit further, we see the muscles of the anus leading up into the rectum that leads up into the belly. The pelvic floor muscles, which we're going to talk about in the next slide, but I want you to see from this representation too, go from the coccyx all the way forward and attach up and near the pubic symphysis in the front. So they come all the way from the back to the front. So you can imagine if the pelvic floor goes into spasm, how it might close down this vaginal opening. You can imagine how if the pelvic floor goes into spasm at the urethra, it might make emptying your bladder difficult, just as it might make emptying your bowel difficult if there's spasm in the anal sphincters. This is again looking up. The legs would be on either side again. Where's my pointer? Up on either side again. But we've removed the layer of skin, the hair, and the fat from this area to show you the superficial pelvic floor. When we talk about the pelvic floor, we refer to it in two layers. This is the superficial pelvic floor. Down below, you'll see the deep pelvic floor. But the superficial pelvic floor almost forms triangles of support around the vaginal opening on either side, and then has fibers that continue almost in a figure-8 pattern to form the external anal sphincter. That then comes back and attaches to the tailbone of the coccyx. If we look at the deep pelvic floor, again, from the picture I showed you before, cut down the middle, you can see how that pelvic floor really goes all the way from, this is again the pubic symphysis, comes all the way from the front, circles around, and comes back up on the other side. Comes back to the back, attaches to the base of the spine at the sacrum and the coccyx, and comes around. Pictures are great. They're very one-dimensional. This is a picture of the model that I use in my office, which kind of helps give my patients a better appreciation of how things really are quite rounded. This is the superficial pelvic floor as you saw before, but you may be able to get a sense that the deep pelvic floor is more almost a bowl shape. It really creates a sling of muscle inside the pelvis that helps support the organs. Right, yeah, so who needs to know all of that? Well, the problem is that the pelvic floor muscles and those organs that I showed you on the inside, and as I talked about, really do have an impact on how wide open your vaginal opening is. And after a series of urinary tract infections, yeast infections, bowel problems, the brain remembers that, and it remembers that the last time you tried to put something in there, it didn't feel very good. So it, when you try to do that again, contributes to pulling in as well. The good news is that we can work on those things, and they can get better. These are the infamous Kegel muscles. They're really quite important. As I said, they help support the organs. They help control your bowel and your bladder with urination and defecation. They're really, really important in that they contract and relax with orgasm, and they actually form the base of our core support. So they really are important, that it really is important that we have functional pelvic floor muscles to help with all of these different things. Pelvic floor muscles are the #1 problem that I see and I treat in women who have pain with intercourse, men too, pain with intercourse. So what can we do? Well, let's give it a shot. Everybody there, I want you to sit up if you can. Put your back up straight. Put your feet flat on the floor. And thinking again of the pictures that the pelvic floor muscles go from the front, just underneath your pubic bone in the front, all the way to the tailbone to the back. I want you to think about pulling up and in like you're holding back gas and urine. As you do that and you think of my model, think of those muscles coming up and into your pelvis like you're holding back gas. And now let it relax. I don't want anything on the outside to move. I don't want you to squeeze your butt cheeks. I don't want you to raise your eyebrows. I don't want you to open your mouth. I just want you to squeeze on the inside. However, and I didn't put this on the slide, if you have a history of pain and it's a problem, you may find that you can't do this very well. And again, therein lies the problem. We need to deal with pelvic floor tension for whatever reason it's there and start working with these exercises. You can go ahead and start trying to connect with your pelvic floor, but in no way do I want it to make your pain worse. If you start doing it and you make your pain worse, I want you to stop. Also, something that I didn't put on this slide is it used to be, we used to tell people to do their pelvic floor exercises in 2 different ways. While they're emptying their bladder to try to stop the flow of urine, we don't want you to do that anymore. There are over 20 reflexes in and around the pelvic floor and bladder function, and if while you're emptying your bladder you contract your pelvic floor, you shut your bladder down and it doesn't empty, so we don't want you to do it there. We really don't want you to do it at stoplights and stop signs either. It's like thinking of training for the marathon, and every time you stop at a stoplight, you get out of your car and you run in place. It's just not very functional. So best place to do it, actually not while you're sitting, is while you're laying down with your knees up in the morning and at night. In the morning after you've gotten up and emptied your bladder, and at night before you go to bed at night. This is not what we're looking for. We don't need an Olympic strength pelvic floor that can hold up 35 pounds and not scream. This is a slide that's been running around the internet, or did a couple of years ago. I can't even remember now where I got it from. Right, so what can I do? You know, it's really what can we do? Pain with sex isn't just the girl's problem or the one who's having the pain problem. It takes two. Communication is absolutely the #1 goal. You have to talk about it. Foreplay happens 24/7, 24 hours a day, 7 days a week, and you really must talk honestly about what's going on between you. Lubricate, lubricate, lubricate. I had to throw this slide in. I wasn't sure exactly where to put it, but this was as good a place as any. You can use olive oil. You can use coconut oil if you're just doing exercises with yourself and trying to do different things. If you're using a condom and trying to have sex, please don't use an oil because we think that the oil can degrade the condom. Water-based lubricants typically are the best. There are also silicone-based lubricants. There are a lot of them out there on the market. Please, please, please don't hesitate using them. Don't be so proud not to use them. So let's talk real quickly before we end about Sex 101. First of all, you have to agree, step one, to work on the issues at hand. You really have to communicate. If you have a partner that's worthy of being your partner, they're going to be willing to work with you. If you talk through this, they're not willing to work through it with you, they may not be the best partner for you to have. I know those are harsh words, but that's oftentimes the way it is because, once again, we know boys and girls don't think the same. If you don't talk about this and go through this, boys are going to think of 101 different ways. Well, let's just try a different position. That's got to help. And you're on the other side of the bed thinking, how can I get out of this? We own the vaginas. We are certainly in charge, but we have to figure out ways to get in there without having pain. Step two is I want you to start to snuggle and hug and kiss like you did when you first met. You know, when you first looked at each other and your whole body tingled and you didn't have sex. I think that still happens. I'm not really sure. I want you to agree not to touch the special parts, no sex parts here, but I want you to find areas on your bodies that just feel good. Not sexual. I don't want anything sexual, but I want it to sensually feel good. It might be the top of your head. It might be your belly. It might be, I don't know, it might be your earlobe. Who knows? Find an area on your body that you really want your partner to touch because it really feels good. It might be a back rub. Back rubs are incredibly sensual. Not sexual, but they certainly can help to lead to sexuality. You have to get to the point where you want your partner to touch you and it feels good. After you've gotten that accomplished, the step 3 is to start to touch the breast, the vulva, and the penis, if there's one involved. But don't forget the lube here. Still no sex, and don't just go right to the breast and don't just go right to the vulva, guys. Back off to step 3. Remember the kissing, the hugging, the snuggle, and the sensual parts. You can't just jump in bed with her and go straight to her boobs or straight to her vulva. It just really doesn't work very well. Still no sex, because what I want you really to do is learn to enjoy the feeling of touch so much on your genitals that you're starting to feel sexy again. So much so that you just can hardly stand it because you've agreed not to go all the way. Once you've done that for a bit, and you really can't stand it anymore, but you've mastered those first 2 steps, you're finally able to try to have sex. But again, start at the beginning. Don't jump in bed thinking you can go there because you've done all this work beforehand. It's a process. You have to warm up. You have to feel good about touching each other. And then you have to be sexually aroused before you can try to penetrate. Fireworks probably won't be there at first. It's pretty darn it's pretty darn mechanical at first, but you have to get through that to convince your brain that you can do this. Try to control the depth and the speed of penetration, whether it's with a penis or a dildo. Go slow. Again, lubricate, lubricate, lubricate. My patients oftentimes tell me that being on the top is best for them because they can control the speed of penetration. I also think that if they're able to get inside, that rocking on top is a whole lot easier than thrusting if the guy's on top. Give it a shot. You can also use your pelvic floor, thinking of the exercises that you did, by contracting and relaxing. It's just what we said. If the muscle's contracted, the size of the opening is smaller. If you contract and then relax as you're trying to have penetration, it oftentimes helps. And if there's a penis involved, guys think it's really cool that they can feel your muscles contracting and relaxing around them. It's a nice little hug. Still no pain. There shouldn't be pain higher than about a 4 out of 10. If there is, you need to stop. You're not ready to have penetration. So is there anything else out there that can help? There's a wonderful book out there called The V-Book. It was written by Dr. Elizabeth Stewart. You should be able to find it on Amazon. It has gone through 1 revision. It's a great book. She's a physician, a very kind, gentle physician who started out as a nurse, and she's just got a wonderful, wonderful review text. There's a lot of information just in boxes. You can either flip through and read the boxes. Your partner can flip through and read the boxes and find out that, oh geez, what you've been saying, they're saying in this book, so it must not be you, you must not be crazy. You can take it to your doctor. You can say, do you see this? Look at this. This is what I've been telling you. It's a great, great reference book. National Vulvodynia Association, ISSVD, Pelvic Pain, IPPS, and Women's Health PT are all places that you can go to try to find help as well. Beyond the Bedroom is actually going to present 5 weeks to pain-free sex. I'll be doing weekly sessions that will talk much more in depth about anatomy and physiology of sex. We'll go much more into detail about hints for painless, to decrease the pain with sex. Talk more about a lot of things that you can do at home to make this better. I tell my patients all the time, I don't fix them, they fix themselves. I just give them a roadmap. And we'll also have real situations and real solutions. We'll ask you to actually submit your stories, and hopefully we can talk about them in the live sessions each week and get some sense of what help you need and what things I can do to help. Just for the record, I am also available for phone consulting if that should work, for things such as helping you find physicians or women's health PTs. I can't guarantee that I'm always successful, but I get calls all the time and I do my best to do that. I'm also reachable by email at healthyexp@gmail.com, or you can also look at my website at deehartmann.com, where you can also submit questions, and questions are always appreciated. I love questions. I'm online all the time. I may not be at your question in 24 hours, but I try to get to them as quickly as I can.
Well, and speaking of questions, we did have some people who submitted some questions ahead of time, and so a number of them you did cover. There's one, a woman who says, I had a recent hysterectomy due to having chronic endometriosis, and it's been almost a year and sex is still slightly painful. I'd love tips to help end this. What do you have to say to her?
How about it? Women who have a history of endometriosis typically fall in that category of women who have had horrible, painful periods. So we see a lot of the same physical problems in women who have had a history of endometriosis and then hysterectomy, as far as muscle tension, bladder tension, rectal tension, all of those things that then combined with pelvic floor tension cause pain with sex. All of the things that I have talked about we can do. The problem with someone who has had a hysterectomy, we always have to remember that that really gets rid of the biggest source of their estrogen. Once women lose estrogen, either through being hysterectomized or through going through menopause, that tissue at the opening gets very thin, gets very frail, and you stop producing as much mucus. So again, big time, lubricate, lubricate, lubricate. Again, I love coconut oil. It's very natural. It's very nurturing to the tissue. I have also used a lot of vitamin E mixed with a safflower oil or sunflower oil in the past, and I actually use it on my gloves here in the clinic, and I suggest that women use it if they're not using condoms with intercourse. It can be very soothing to that vulvar tissue. Even women who have had cancer, who have had radiation perhaps, if they've had either uterine cancer or vaginal cancer and they're very dry, using coconut oil is a wonderful adjunct to help with pain.
What about women who have been pregnant, given childbirth, not through C-section? What do you have to say to them?
And they're having pain?
Yeah.
Well, it's, we never can say, people always ask us, or I hear that physicians tell patients, well, if you just hurry up and get pregnant, this would all go away. And in my experience, that hasn't been the case. We never really know that a vaginal birth is going to eradicate this problem. I have had patients who have been totally pain-free, gotten pregnant, had a baby, and then starting having pain with sex. Sometimes it can be problems with the episiotomy scar. That can be an issue. And if a woman is breastfeeding, her estrogen levels are also very low, and she too can have pain with sex. Having a new baby and sex with women oftentimes doesn't go together very well anyway. But there certainly are physiological problems, and we'll talk a lot about that in the 5 weeks to pain-free sex. There's a lot of anatomy and physiology that goes along to help explain some of these things. We'll talk a lot about that.
Okay. So another question was male ED or men that have had their prostates removed, any kind of prostate surgery. We haven't talked a lot about men tonight. What do you have to say for men in that category?
We know from the literature that the pelvic floor is very involved with male orgasm as well as male erection. If there's problems, if it is post-prostatectomy, if there's been a prostate removed, or if there have been issues of chronic pelvic pain, the male version of the stibulodynia is prostatodynia, if you can imagine such a thing. Men will go to their urologist complaining of pain and burning in their testes, in their penis, and their doctor, unfortunately, their first line of defense is it must be prostatitis or an infection in your prostate. Here, try this antibiotic. It doesn't work. Well, let's try this one. Well, let's try this one. And they go through a long series of antibiotics with no resolution of their pain. So many times it's a problem with the pelvic floor. Once the pelvic floor gets into that tight spasm, you can't either have a successful erection or you can't ejaculate or orgasm. Men with post-prostatectomy often have the opposite problem where the pelvic floor is very weak, so it's not able to contract and hold the base of the penis to help the blood stay in the penis for a healthy erection. We've found and we know through the literature that by working on pelvic floor function, we can improve sexual function in both the hypertonic, where it's too tight, and the hypotonic, where it's too loose.
Wow, Dee, this has been amazing. There's a lot of information you covered, and I'm just briefly going to talk about bullet points that I heard. Communication, lubrication, both are key. I also heard you mention practicing sensual, non-sexual touch, sensation play, and how we just want to focus on the pleasurable sensations in our body. That can be part of foreplay. You talked about patience, patience for yourself, the woman who is having the experience of chronic or situational pain. You also talked briefly about patience in relationship to a partner who's going through this. Beautiful. I really like the fact that you talked about how each person is her own and or his own advocate. It is unfortunate that we have to educate these doctors, but let's be honest, they are thrown so much material in med school. By empowering our listeners, our audience, certainly for this webinar and certainly at Beyond the Bedroom, we're arming them with information that they can take to use their own voices, to get those doctors to point them in the appropriate direction to help them alleviate pain. It's really, you get to ask and tell your doctor this information so that they can direct you to getting the help that you so actually oftentimes desperately need.
Yes.
I'm really excited to go through the 5 weeks to pain-free sex with you, Dee. I really look forward to hearing much more in-depth information. I know that you will be talking about men more so in relationship to chronic or situational pelvic floor pain in that class. And there's so much that our audience will be able to do based on those 5 different sessions, 5 weekly sessions. So audience, definitely stay tuned for more. We will give you the information on how you can sign up for that webinar. We will definitely go into more bullet points as to what you can expect and why this course would be important for you. Stay tuned. Thank you. I believe Dan is going to come on for a few closing. The questions that weren't answered, please feel free to submit additional questions to us. In addition to Dee, she obviously has posted her contact information, and you all should know how to get in touch with us at bedevent.com or on our Facebook page. We are happy to review those, and hopefully we'll get to as much information as we can. Definitely look to educate you more and help you more in the 5 weeks to pain-free sex. So
Fantastic.
Dan, are there other things you want to say in closing?
No, I think that's it. I think we covered most of the questions that people had sent in. I want to also thank Dee for being here with us tonight. I've learned a lot myself. We can't learn enough. It just is amazing how much information is out there and how much misinformation is out there. So by bringing in experts in different areas, we all become much more knowledgeable, which makes us much more powerful around our sexuality. And sex should be fun. You know, sex should be playful and enjoyable. And if it's not
pain-free.
Exactly. If it's not pain-free, then it's really not worth it. And I'd love to be able to provide this kind of information so that we can take back control over our sexuality and enjoy it.
Fantastic. Thanks, you guys, so much.
Yeah.
It was such a delight. I really enjoyed this.
Yeah. Well, I look forward to many more in the future, and especially the 5 weeks to pain-free sex that'll be coming up soon. And for people that want more information about that, it will be posted up on our website shortly. So love to see you all there soon too. And
Thank you, everybody, and thank you
Thanks,
again.
guys. Thanks so much.
Bye.
Bye.
Bye-bye.
Bye.